So yeah.
Okay, I will just start recording.
That was
So today,
very good.
yes,
That was
today
very
we will.
good. But since 2012, I have
Okay,
stopped using nitrous oxide because I got B12 deficiency.
okay.
Okay, and afterwards I am avoiding nitrous oxide.
Okay, so actually, this is because majority of people who are working in anesthesia are unaware of this concept
Let
of
us start.
opioid-free anesthesia.
Let us
And
start.
before, like, if we want to consider this thing, the thing which is very important for us is to just think what are the things which are not nice about opioids. Okay, of course, the thing which you pointed out, Dr. Abdurrahman, related to vitamin B12 deficiency with nitrous oxide, it is something can you just think what are the ways, different ways to avoid this problem? The problem which you face
No,
because of
actually at
nitrous.
that time, actually at that time,
Hmm.
I was uh, I was holding the mask, okay, for 2 hours. That time I was a young and a healthy guy. Yeah? So
Okay.
it was my youth. And sometime even I was holding the mask for 2 hours.
Okay.
Okay, for
Okay.
and
So
then
actually,
you
yes,
see
you are
the
right.
most of the waste of the anesthesia, waste of
Okay.
the anesthesia is anesthetic is during the mask ventilation.
Sure.
when we
Sure.
when we are holding the mask with the high flow, then with the environmental pollution is very high. So after I was diagnosed with a vitamin B12 deficiency, I stopped using the nitrous oxide. Now I am not using nitrous oxide. And
Okay.
otherwise, I
Actually,
am using I am in my routine patients. In my
hmm,
routine patients for general anesthesia, I
hmm.
am using dexamethasone, okay, with the induction, and then ketorolac and paracetamol.
Okay.
There was
Okay.
other option that we can give if the surgeon cooperates with us, then we can add pregabalin. That was
Hmm.
one suggestion, but it could not be
Yes.
materialized.
You see, this is
Pregabalin, that
the things which you are pointing it out. Actually, this is opioid-free anesthesia. The points which you are mentioning now, this is the concept that what are the ways by which we can reduce the use. Actually, opioid free anesthesia doesn't necessarily mean that you have to make it totally forbidden. Okay, it is to avoid and minimize the use of opioids and use them tactfully, and introducing other medications which can help in reducing the doses. So that is a, so first of all, because the point which you mentioned about nitrous oxide, there are certain ways to reduce this thing. Reduce this problem with nitrous oxide. One of them is scavenging. If you have a proper scavenging system, you can avoid operation theater environment with nitrous oxide. Number two is agent analyzer. You should have agent analyzer, and by which virtue of agent analyzer, you can monitor how much nitrous oxide is there in the gas flow, and then you can optimize accordingly. Low flow anesthesia. This is my one of my darling these days. One of them is opioid free anesthesia, and the use of low flow anesthesia since many years, till because I have discussed this low flow anesthesia before. Few you can find this discussion recently. In recent past, I had discussed this topic. Low flow anesthesia is the way by which you can reduce the exposure to nitrous oxide, and of course you use of TIVA as much as possible. So by that the way you can avoid the problems related to nitrous oxide. So before going into this opioid free anesthesia topic, uh, there are certain why you don't want opioids. So opioids, one of them, the problems which you can face with opioids is PONV. One of the problem which you face is ileus. One of the problem which you face will be pruritus. Okay, one of the things will be like opioid dependence later on. Okay, and another thing is actually, just tell me, can anyone mention at which place in Pain Pathway Opioids Act? Yes. Any answer from a resident? At which step of Pain Pathway Opioids Act?
Opioids are like these are these are most of them are acting on the kappa receptors. No?
No, but which step in the pain pathway? Like there are four steps. One is transduction, one is transmission, one is modulation, and one
Yes.
is perception. So what do you think where they act?
Yeah, I think they are modulation and perception. They are in the final stages. The initial stages they don't help. No?
Modulation and perception mainly. Okay, there are certain peripheral role of opioids, but that is mainly in modulation and perception. So actually they have nothing to do with the in like for example, if we are giving NSAIDs, for example, okay, not only it is reducing the pain, it is reducing the source of pain as well by decreasing the inflammation.
Yes, yes, it will. Yes,
when we are
cycloxy pathway.
when we are giving steroids, actually they are also acting as an anti-inflammatory, and they are decreasing the inflammation. Okay, so similarly, opioids, when if like we use remifentanil and higher strong opioids, in that way they are also decreasing the stress response. But reality is that whenever we are using can someone mention, because I'm just trying to bring to the point that all opioids which we are using, actually they are creating more problems than help, but we don't realize. If you ask a surgeon, ileus is the biggest problem post operatively, especially in abdominal surgeries. Okay? And even in other surgeries, even in if they are doing other surgeries, even then like these opioids are creating too much problem. Okay, and because this is actually another point which is not directly related to it, but fluid administration is a big problem from our side. Have This is a question: have you got any patient in your domain which is without having any cardiac dysfunction? I'm just trying to make my cardiac dysfunction. Okay, going in overload. Have you ever faced just by giving fluid?
Yes, sometimes it happens.
mm, I actually I
But
will repeat.
particularly prolonged surgery, no? Particularly prolonged surgery. Sometimes
Okay,
I like to, yeah, we are talking about the SA1 patients. No? So
okay.
prolonged surgery, sometime it happens.
But actually in my but my point is that usually we are not giving adequate fluid. We are always keeping our fluid low in volume, just in the fear that patient will go in overload. In my 18 years career, I have never seen a normal patient without a significant cardiac dysfunction going in overload. Pediatrics are something else. In pediatrics, inadvertently, you can give more fluid. But in adults without any cardiac dysfunction or renal problem, normal surgical patients which are coming for any surgery, I have never seen. Anyways, this is personal experience maybe, but usually, in my opinion, we are giving less fluid. So when we are giving less fluid, and actually another thing, normal saline. So this is creating more problem, especially when you are giving with reference to ileus, if you are giving too much opioids and you are giving non-balanced salt, instead of ringer lactate, we are giving more of normal saline. So this patient is prone to have hypokalemia. Okay. So and so this will be exaggerating the problem which are there because of opioids. Okay. So with reference to
So
remifentanil.
in my practice, I will giving at least for like those who have say one patient coming for laparoscopic cholecystectomy or laparoscopic hernia repair or some these procedures. I give minimum 1 liter, 1.5 liter.
Okay, okay. So you're right. Anyways, with reference to remifentanil, can anyone tell that what is the problem you can face when you are using remifentanil? Dr. Abdurrahman, maybe you have put something because now your voice is not coming clear. It's coming with too much echo. So maybe you
Post-operative
have
pain.
post-operative pain. Remifentanil is associated with opioid-induced hyperalgesia. Can can anyone explain what is this hyperalgesia? I'm
Yes, the
sorry, I'm
requirement for the requirement for the post-op, no, post-op analgesics as well increased.
no, no, it's not like that. Actually,
Uh,
remifentanil is rapidly
yes,
metabolized, okay? And if you have not given replacement analgesia, it will suddenly cause severe hypertensive response because the analgesia which you were achieving with the use of remifentanil is metabolized in the blood immediately as quick as 3 to 5 minutes only even, okay, because its context sensitive half life is only 3 to 5 minutes. And can anyone tell what is context sensitive half life? What
At
is
which
context?
50% of the drug is metabolized.
No, my dear. No, my dear, it's not that.
uh, sir, context is related to duration of infusion.
Very good. So context sensitive is what now? Explain further, Tayyab. That if
Sir,
infusion, if any medication is given in infusion, and in how much time its effect will finish. Okay. So that is context sensitive half life. So it is even for hours if it is given. If you stop it, remifentanil will vanish. So when remifentanil will vanish, suddenly there will be severe pain. And actually, personally, I have faced at least 2 times very terrible hypertensive response because I had not properly replaced it with other analgesic. Okay, because I had given morphine. Okay, without thinking that morphine will take at least 15 minutes for its effect. And actually, maybe I had given less of morphine. So what happened suddenly from the copy paste, because remifentanil, what is the beauty? The blood pressure will become like copy paste, 160, 160, 90, 60, 90, 50, 80, 50. The blood pressure will be copy paste. And suddenly when you close it, I give it, I stop it, and I had given morphine, and I stopped it. So what happened? Suddenly blood pressure. So this is a terrible problem which can create a lot of problems. So whenever you are using remifentanil, you have to replace it with other opioids. Otherwise, there will be severe pain immediately. Okay. So this is the problem with even the best test of opioid. Okay. Let's talk about fentanyl because the
uh,
opioid which we use
sir,
in yes,
then we should do bridging therapy even
very
before
yes,
stopping.
yes. You should if you are using remifentanil before if you want to give it you should there are you two options either you give morphine 15 to 20 minutes and then you wait 15-20 minutes and after that you close so you have a surety that morphine effect has already been achieved or there is another option that maybe 3 to 5 minutes before you give fentanyl because fentanyl is rapidly fentanyl effect will also come quickly so you can give fentanyl morphine and fentanyl both. Okay. And then what will happen that because the problem with fentanyl and so because in most of the centers where fentanyl is available fentanyl is being used like a holy water. Okay. But actually the reality is that even whatever dose you have given it will not remain in the circulation between 50 to 30 minutes because it is highly lipid soluble. It is highly lipid soluble. Okay, so what happens that there is no guarantee that you will be able to achieve the steady state or you will be having the levels of fentanyl maintained throughout the surgery. So either you will have to repeat it again and again, or if you want to use fentanyl, because actually I have this argument with a number of people who are using fentanyl, they don't have clear answer, because they are giving fentanyl maybe 100, 200, and after some time, effect is finished and then they have to repeat it. Okay. So unfortunately, I differ with their concept. If they are using fentanyl, they should give it in infusion. That after giving a bolus of 50 to 100 mics, like at least 1 mics per kg or 2 mics per kg bolus. And after that, you have to maintain a dose of around, say, 1 microgram per kg per hour or 2 microgram per kg per hour. Otherwise, you cannot maintain the pain only with fentanyl. So that's my point. Okay. The other way, you should give morphine. The people, unfortunately, in the part of world where Pakistan, there is no morphine. Morphine is available on the roads, but not in the hospitals. But if you are using morphine, people, what I have seen, that people are using morphine at the end of the surgery, because in their concept, you should use morphine at the end of the surgery so that it will cover post of pain. I don't understand this point, because my point of view that if you want to use opioids, use it correctly, because people are using fentanyl at the start and they are giving morphine at the end of the surgery. But in my point of view, that if you are giving morphine before start of the induction, by the time they will give incision, the morphine effect will already be there. So you will have a better analgesia profile as compared to if you are comparing it with a bolus of fentanyl. And again, fentanyl will run away from the circulation and you are running behind fentanyl to bring it back by giving more and more. But if in other way around, if you are using, for example, opioid, morphine is a better choice uh, with comparison to fentanyl. If you are using it, if you are using opioid, not the opioid free anesthesia concept. Okay. So now few, because we are going to, I am short of time. I have taken more time. Now I will come to what my point of view is, or what the concept of opioid free anesthesia is. That actually, this is also called as multimodal analgesia, that you should use paracetamol, NSAIDs, lidocaine, and my D for dexmedetomidine, and D for my darling dexmedetomidine. Okay. So dexmedetomidine is a medication which is comparable, even superior. Yes, it will take a little bit more time than fentanyl, but its effect is much superior, even for blunting the endotracheal stress response, as compared to fentanyl. The only problem is that how you should use it. Because if you are using it with, ideally you should be using it with the syringe pump, and actually there is a lot of variation in the dose requirement. Maybe some patients will require less, some patient will require more. As much as you will use, as much you will. So you can start with a slightly lower dose of, for example, 0.1 to 2.2 microgram per kg per hour, and gradually increase it. Or you can increase with slightly higher dose and then you can come back. Or practically, this is again, this is non-technical, but what I do, that I put a small, very small amount, like 10 to 20 mics of dexmedetomidine in a dedicated line, and I just titrate the heart rate with the rate of the infusion with the heart rate. That as soon as I get the required heart rate, I stop or I decrease the rate accordingly. And whenever you are using dexmedetomidine, you should have glycopyrrolate and atropine with you, because dexmedetomidine can cause bradycardia. But of course, this is in your hands and you can control it by the way you are using it. But if you are only tuned to typical induction, unfortunately, you cannot use it, because for dexmedetomidine, you have to be awake, you have to be very vigilant, and you have to use it with a purpose. Okay. So other thing which you can use is lidocaine, and lidocaine not only as a bolus, you can use it in infusion. Like usually, what we are giving a dose of 1 milligram per kg bolus for the blunting of stress response. Okay. So I will tell you the same thing, that you can give 1 to 2 milligram per kg per hour infusion titrate it to the effect. Okay. So this is another alternative of opioids when you are using it. Okay. So lidocaine infusion, and it has very I will quote the example that there are so many studies which are being done in which they have stopped using epidurals in colorectal surgeries and they have replaced it with lidocaine infusion. So they are giving it, and of course, this will be done with the infusion pump, like 1 to 2 milligram per kg per hour. Of course, if you have some contraindication, allergies, or some liver problem, then the situation will be different. But you can use lidocaine for the blunting of stress response. Okay. So I'm just trying to wrap up what I'm trying to say. So like lidocaine is one of them. Dexmedetomidine, again, if you open the book, you will find that there is a loading dose and there is a maintenance dose. Unfortunately, I will defer to this point of view. Practically, if you open the book, you will find this thing. But this is what I'm telling you. At least 1 to 2 year constant use of dexmedetomidine, what I have learned, that the more of the problems which we face with dexmedetomidine is only following the bookish dose, which will not be true for every patient. So sometime maybe you need more, and sometime you need less. So if you open the ampule and calculate with the calculator and give a bolus or give a fast dose, thinking that this is the dose of dexmedetomidine, unfortunately you will create a problem. So the better way is that you use it in a way that you titrate it rather than just fix dose, and you will get a wonderful experience. Like I'm just giving you example for today I was doing day surgery, 5 to 6 cases. Believe me, I did not open any opioid. I control only with paracetamol, zifo, of course, 70-30 combination of nitrous oxide with low flow anesthesia, and with Presidex. I even did not use today ketamine. I just try to think it. Just try to just because usually I'm using a very small dose around 0.25 or point 0.2, uh, even less than that, like around 20 to 25 milligram of ketamine bolus at the time of induction. Okay, as a analgesic. But even today I deleted it, and I wholly solely gave one ampule of dexmedetomidine, taken under sterile condition with the separate syringes for every patient, even maybe the whole day of 6 hours, 5 cases, short cases. Even the recovery was very smooth, pain free, and no opioid. Believe me, today I'm just sharing with you that person. That's why that triggered me to you discuss this topic today. That you can do it. Dexmedetomidine is available very freely in Pakistan now, even. So, but for that you should have a baseline knowledge, and you should have a baseline concept of how to use it. Otherwise, you will invite a lot of problem. Okay. So similarly, you can then the another thing is that when you are using these medications, then with passage of time you will devise a combination. Like you can use a small combination of lidocaine with Presidex. Of course, you have to be careful about the heart rate. You have to careful about the blood pressure, the hemodynamics, and of course, you will rule out patients with certain heart conditions and certain other comorbidities. This will not be true maybe in ASA3, you say ASA4 patient with some cardiac problems. Okay, this is true with usually with ASA1, 2 patients without any baseline problem which can increase this. Like for example, if you listen to me that lidocaine can be given 1 to 2 milligram per kg per hour, and you are using it for 7 hour surgery in a patient with having liver dysfunction. So like maybe one bolus will not do anything, or even 1 to 2 hour, nothing much will happen. But if you use it in a 7-8 hour surgery with liver dysfunction, this can create problem. This can lead to toxicity. But otherwise, if you are using it in even there are studies that lidocaine infusion is even continued post-operatively in ICU for the whole of the initial maybe 12 to 40, 24 hours post-operatively even. So that will give you an excellent analgesic effect. Even lidocaine infusion is being used in cancer patients as well for analgesia. Anyways, so other things which you can use with the same way. Again, I will repeat that: give a dose of paracetamol. Okay, give a dose of any NSAID, whatever. If there is no contraindication, give a dose of NSAID. Give dexamethasone. Dexamethasone is a magic. It will give you for everything. It is there for PUNV, for anti-inflammation, for increasing the effect of nerve blocks, for increasing the effect of analgesic medication. So dexamethasone is use it as a like a multi-dimensional thing. Okay, and of course you will be using some anti-emetic as well. Okay, because why it is important that overall, if you like consider, if you think you are thinking about overall profile, the advantages which you are getting with the avoiding opioids, is one of them is PONV. Okay, so like there will be better outcome if you are not using opioids. Okay, or even if you are using it, maybe like post operatively, if still there is pain, maybe you can give a small dose of pethidine, because pethidine is very famous among the PACU staff. PACU staff is giving intramuscularly, and they are very happy with it. So but at least with your hands, I'm just saying that you are keeping you pulling yourself out of the sin, because opioids actually, have any one of you received opioid? Actually, I received at 2 times in my life, and I found it. I don't find that it was treating my pain actually, but I was very relaxed because it was making me in another world. So now that's why I think about the addicts, that how much they are enjoying their life, because when they are receiving opioids, they are away from the pain. They don't feel it. They don't know what is happening. But actual pain is there, but you will not appreciate it because your mind is lost. I was bitten by a scorpion, and that time I received opioid for the first time, and then I realized what opioids is. Anyways, so dexamethasone is one of them. Then you can give a dose of bolus of lidocaine followed by infusion, dexmedetomidine. Okay. And if you are using, for example, nerve block, so nerve block will be a big help to you. Okay. Either if you are not giving nerve block, even local infiltration, offer the surgeon, offer the surgeon local infiltration always, whenever possible. Please request them to give local infiltration. Please, can you give some local before incision? This will, they will be looking at, sir, we will give it at the end. No, please give it before incision as well. Ask them to give it lidocaine to start with, and tell that bupivacaine you can give at the end of the procedure, because it will because lidocaine is fast acting, its effect will come early, and bupivacaine will remain for more time. So that's how you can do this thing. Okay. Then there are certain other medications which are being used. One of them is magnesium sulfate. Magnesium sulfate is also being used for stress response, blunting of stress response. Lidocaine, dexmedetomidine, their effect is actually like dexmedetomidine, it is alpha 2 agonist. So it is central, it is acting on central nervous system, and it is, you can say it is like our grandfather. When grandfather is there, nobody is creating any noise, no girgir. Okay, so it is decreasing the heart rate, it is decreasing the blood pressure. So the response to the pain is not there. Okay, and if you have combined it with paracetamol and NSAIDs, you are blocking the inflammation as well. You are blocking the, and actually paracetamol and NSAID should be given before there should be a mechanism in the hospital department that you are giving paracetamol and NSAID before the surgery. That will be the best way. Another medication which you can add with paracetamol and NSAID is pregabalin or gabapentin. Okay. which is also being used to has opioid sparing effect. The problem again will be a little, because in different population groups, the effect of gabapentin is different. So maybe it may lead to a little drowse patient, a little drowsy. With dexmedetomidine, again, the problem is that sometimes dexmedetomidine will make the patient a little drowsy, but the respiration will not be depressed. The good thing is that patient will be breathing very nicely. Maybe patient will not be responding as you want, but after some time, the patient will be awake. There is less incidence of shivering. There is less incidence of agitation. So dexmedetomidine has so many good effects, but unfortunately, because people are not aware of it, so sometimes they will not be accepting this thing that what you are doing. Okay, but this is the beauty of this. Yes, Tayyab.
Sir, I have one question. Dr. Abdurrahman told pregabalin can be used in preemptive analgesia.
Mm-hmm.
But another thing, what he said was that however, it should not be established. My question is, what are the causes why it should not be established?
What
And
do you mean by
another question
established?
is, sir, how
I
to
don't
use
understand, Tayyab.
magnesium?
I'm sorry. Repeat your question. I don't understand.
Sir, Dr. Abdurrahman told use of pregabalin should not be established.
I'm sorry. Maybe I don't know whether he said or not.
Okay, sir, another is how to use magnesium sulfate as bolus or
Magnesium
infusion.
sulfate also infusion. I don't have personal experience regarding magnesium sulfate. Okay, so I cannot comment too much. Yes, Dr. Sharjil, thanks for your comment. Dexmedetomidine, that I mentioned that dexmedetomidine, if you have a patient with some comorbidities, then it can create some problem. Similarly, I did not mention too much about ketamine. Ketamine is NMDA receptor antagonist. Ketamine, the advantage of low dose ketamine is that it will not create the unwanted effects which are labeled to it. It is increasing pulmonary pressures. It is increasing SVR. It is increasing heart rate. It is not there if you are using in a small dose. Okay, I worked 2 years in a cardiac center, and you will be surprised. And all the pediatric patients with all the bloody cyanotic heart diseases, with all the bloody pulmonary hypertension, always they are inducing with ketamine. So I was just looking at them what they are doing, because theoretically I was told don't use ketamine. Ketamine is very bad, but actually ketamine is a wonderful medication. Even if you are using in any patient, I can say by surety, if with low dose 20 milligram or 10 milligram or 15 milligram or very low dose of ketamine will give you an excellent analgesic effect on top of the other medications which you are giving, and it will slightly reduce the requirement of propofol, which will actually help. Even for example, you are saying you have a cardiac patient and you don't want a stress, so if you are giving a small dose of ketamine, it will reduce the requirement of propofol. If you are giving a small dose of midazolam, and if you are using a small dose of dexmedetomidine in combination with paracetamol and NSAID, the advantage will be the requirement of propofol will be reduced. So when you are reducing the requirement of propofol, the cardiac depressant effect of propofol will not be there. Patient will sleep early, and you will have the intubating conditions in a better way. Okay. So similarly, another point to be raised is that usually we are not using the proper doses of muscle relaxants. Okay, you will be saying, oh, because the thing is that when you are using slightly low dose of muscle relaxants, actually you need to ventilate the patient for more time. You need because when you are using maintenance during the maintenance of anesthesia, if you are using less muscle relaxant, the requirement maybe it looks weird, look weird a comment, but if you are using less muscle relaxant, you will be needing more mac. You'll need to have more inhalational agents, and similarly if you are using more inhalational agents, the requirement of muscle relaxant will be reduced. So it's a vice versa thing, but actually you should be using a good dose of rocuronium, for example, if you are using it, especially if you have a long surgery. Don't be afraid. Even if you have given a like 1 milligram per kg of rocuronium, the advantage will be that you don't need to ventilate a lot. You don't need to be worried about ventilation. Even in difficult, you will be surprised that the people are using with danger. If, for example, you fail to intubate, you have a backup of sugamedics and you can reverse the patient. If you have given a smaller dose, maybe the patient will be in between and you will have more problem in intubation even, and their stress response will be more. There will be more trouble in laryngoscopy, like all the problems will be more. So proper doses of muscle relaxant without fear, because less use of muscle relaxant will create more problem for your. This is again my personal experience, because when I'm doing lap sleeve gastrectomy, I'm making the ramp position and I'm using Judy. I know that I have a sugammadex. If I am not able to intubate, I will reverse. But if I am trying to, because sometime majority of time in the experience is, the reality is that these very obese patients sometimes are difficult to ventilate, but they are not as difficult to intubate. If you are making a proper position, you will be able to intubate the patient. But maybe with a big neck, sorry, big beard and a big face, you are not able to ventilate nicely. So this is another comment. Okay. So just we will have a look few words what is there in this article of opioid free anesthesia, which was here around 1 year, more than 1 year ago. It came through this anesthesia tutorial of the week. So in the concept of ERAS, they are using it. The unwanted effect like sedation, dysphoria, delirium, constipation, urinary retention, post-operative nausea, vomiting. You will be avoiding a lot of problems related to opioids. Okay, and it will post-operative nausea, vomiting is one of the factor for delayed increasing the hospital stay. So ERAS protocol is also trying to avoid as much opioids as possible, and use of nerve blocks and local infiltration, and there are so many other things which are there. Okay, post-operative hyperalgesia and tolerance due to neuroadaptation increases the requirement for long-acting opioids and is more prevalent with the new short-acting opioids like remifentanil, that what I told you. Okay, surgery anesthesia have a complex effect on immunity. Opioid anesthesia reported to inhibit both cellular and humoral immunity, which can lead to early cancer recurrence. I don't know about much about this point, but they have mentioned it here. Of OFA use response to public health crisis. Patients leaving the hospital with an opioid prescription for postoperative analgesia are at a high risk of repentance. The epidemic use of opioids in United States has caused significant morbidity and mortality within with an estimated 2 million dependent users and others. Okay, so they are saying that this is as a response of public health crisis. That's why just trying to avoid opioids. Okay, these compelling reasons have made clinicians to look into feasible. So they are just telling you pain perception under anesthesia. The concept of pain perception under anesthesia has been questioned recently. In an anesthetized patient, it is more precise to use the term nociception, as pain requires as pain requires a patient to be conscious to perceive it. In a conscious person, a nociceptive stimulus will result in hemodynamics like tachycardia and hypertension, ventilatory response, and behavioral responses, in addition to discomfort. Under adequate hypnosis and paralysis, tachycardia and hypotension are the usual clinical indicators of inadequate antinociception. Thus, our main intraoperative goal is hemodynamic stability. That's what I was telling you. That if you are doing any manipulation, or they are doing anything which is more stressful, like they are doing sternotomy, like they are putting tuck 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 hammer on on the bone, that is the time where your anesthesia will be checked. Otherwise, and another time when they are pulling the gut, at that time your analgesia is checked. So there are so many things which you only, because the pain, the pain requirement does not remain throughout the surgery alike. It goes up, goes down. That's why there is a roller coaster effect which is there. So you have your target, the thing which you are targeting is the blood pressure response, hemodynamic stability, as they are telling here. Okay, so the connection between ascending pathways with autonomic neurons in for form the basis of a horizon heart rate. That's they are telling you the 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 point of view. Okay, so adequate control of hemodynamic response during anesthesia does not guarantee that a patient will emerge from anesthesia without pain. So it is equally important to address nociceptive pathways as well as the autonomic response. Nociception can potentially induce central nervous system changes, including sensitization. This is the rationale for using a multimodal anti-nociceptive, because if you don't give like multimodal analgesia, if you are using alone only dexmedetomidine, maybe you are as soon as the effect will finish, patient will suddenly will have pain. Okay, so that's why you have to use a multimodal approach with multiple medications, with that paracetamol and NSAIDs and local infiltration, so that you are controlling some of the aspects. Okay, monitoring antidotes under anesthesia, they are just telling the same thing, I think. Okay, is it possible to avoid intraoperative opioids? Magnesium sulfate, a number of things I have already discussed with the use of like lignocaine, alpha 2 agonist, beta blockers, magnesium sulfate, ketamine, dexamethasone, gabapentin, and NSAIDs, paracetamol. Okay, so these are some of the medication: alpha 2 agonist, lidocaine, ketamine, magnesium. Magnesium, we will see here, maybe they have. Then is also an NMDA receptor antagonist, in addition to its effect on calcium influx. Okay, anti-inflammatory and opioid-sparing effects make it a popular component of opioid-free anesthesia. I have not used it, by the way. That's why I was a little reluctant to tell. It is extensively used for perioperative analgesia in a dose of 30 to 50 milligram per kg intravascular bolus, followed by a 10 to 15 microgram per kg per hour. Yes, Tayyab?
Here you have checked the first sentence in this up beta blockers.
Yes.
Encapsulin. He is blocking encapsulin. On the other, encapsulins are basically our what we
I'm
say
sorry.
endogenous opioid.
Where?
This up in the this please uh,
Um,
more, take up then ketamine.
yes. Here
No, I can't see. Screen is not moving.
is this one or more up?
Here it is written. It blocks transmission. Block the encapsulins.
This one, hemodynamic stability with opioid analgesia is achieved by blocking
Yes, yes.
encapsulins.
This sentence.
Uh, Blocking encapsulins, I'm not sure about it. Some of many within pain pathways. Mm,
Encapsulins and endorphins. These are endogenous opioids.
I don't think so.
They
Th- I think this is a questionable. I don't understand this point. You are absolutely right. Because they should be helping. Because endorphin and encapsulins are endogenous opioids. Your point is correct. Okay.
okay,
Your point is correct. Okay. So advantages, because actually I'm over time. I was trying to finish in half an hour, and avoids intraoperative opioids by any route, has specific advantages and is indicated in selected group of patients: obese with OSA, COPD, asthma, chronic opioid addiction, CRPS, cancer surgeries for patients with ERAS protocols. Okay. So disadvantages, we can see here few of the disadvantages. Familiarity, availability. The infeto should be used with extreme caution in patients with cardiovascular diseases like AV blocks and in elderly patients on beta blockers. Other relative contraindication to OFA is critical coronary stenosis and acute coronary syndrome, uncorrected hypovolemic shock, autonomic dysfunction. Okay, that's I told you that you will not use these different ways in a patient which has some problems. Okay, so I hope some of the points are highlighted. Dr. Sharjeel, I will appreciate if you have some few comments, please. Dr. Sharjeel is working in UK. Dr. Sharjeel, can you hear me? Okay. Any comments before we finish?
Dr. Zishan.
Yes, sir.
Assalamu alaikum.
Walaikum assalam. Ji, yes.
I'm Dr. Saqib from Makkah.
Yes, sir.
I have just one comment, sir. You have mentioned all the things very excellently. You described this all opioid-free anesthesia. Just one comment that this nitrous oxide, this is a very useful agent. This can be
Yes.
used during anesthesia to avoid the opioids. And for some time, we have almost abandoned the use of nitrous oxide in Pakistan and also here. But nitrous oxide is an excellent agent. It is excellent agent for analgesia during the procedures.
Yes, sir.
So you can use nitrous oxide in 60 to 40%,
Yes.
60% concentration with 40% oxygen.
Yes, sir. Actually, I think you joined. I will just mention because the first comment about nitrous oxide we from where we started, and I just mentioned that if we are using scavenging, we have agent analyzer, we are using low flow anesthesia, then use of nitrous oxide is wonderful. Like there is no problem at all because whatever problem is there is with the long term use of nitrous oxide. In short term, there are so many people who are against nitrous oxide, but nitrous oxide gives an excellent push to your all anesthesia, not only analgesia, opioid sparing, reduction of mag. There is no problem if you are using it with the like, especially if you are trying to avoid the pollution. Okay. So, Dr. Sharjeel, would you like to say something,
Hi,
please?
hi, oh, thank you very much. It was really lovely listening to the whole talk. It was really nice. Uh, I think you have covered everything. You have discussed about almost all the types of analgesics or adjuncts that we can use instead of using opioids. Obviously, in my practice, we can't completely avoid opioids. We do use some sort of opioids pretty much in every surgery, starting with
Yes.
fentanyl. That's in fact one of our favorite analgesics, I have to say. Uh, and we do add morphine, exactly the way you mentioned that we use basically fentanyl to cope with the laryngoscopic response, and then we start morphine straight away. Uh, and we do add morphine at the end as well to make sure that the patient remains pain free. However, our aim always is to reduce the amount of opioids as much as we can by adding all the adjuncts which you have mentioned, especially the nerve blocks, which is, I think, pretty much all the anesthetists are very enthusiastic about blocks.
Yes.
But obviously, all the medicines that we have discussed have got their own side effects. Dexmedetomidine over here in the UK, we're mostly using them this in the intensive care unit, especially when we are weaning off patients from ventilator.
Sure.
Uh, I haven't personally got much experience of using dexmedetomidine in theaters. Yes, in ITU, yes, we have used it a lot, but not in the theaters. Nitrous oxide, which we were just discussing, in UK, they do promote using nitrous oxide, but only for obstetrics, where you want to reduce the MAC value.
Mm-hmm.
But otherwise, they don't promote nitrous oxide because of so many reasons, including ozone effect, which you have mentioned. But obviously, you've got so many other side effects that the patient can face, including all the second gas effect and all the cavities getting filled with the nitrous oxide and anemia and all that stuff. So that's why they prefer not to use it. But weighing the risks and benefits, they have allowed it to be used in obstetrics.
Okay.
Yeah, but brilliant. It was a lovely talk. It's always a pleasure to listen to your talk, Dr.
Thanks a
Zishan.
lot,
Thank you.
Sharjeel. It's an honor
Thank
for
you.
you to join us from UK.
Thank you. Thank you.
Okay. Thanks
Thank
a
you very
lot.
much.
So
Thank
thanks
you.
a lot, all of you, for your presence. And any comments, even later on, I will be welcomed. Okay. Thanks a lot. Thanks a lot, Dr. Abdurrahman, Abid, and Dr. Kamran, and everyone else. Thanks a lot, all of you. Especially Dr. Naseem from Rahim Yar Khan. Okay. And Vanita Deep from my old hospital. Thank you very much, all of you guys. Bye bye.
Thank you, sir. Thank you for the presentation. Thank you.